Well, I think people are starting to join at this moment, so just want to welcome you all, and we'll be starting in a few minutes as we get more attendees. Right. Well, it looks like we've gotten to critical mass there. We'll just let others just start joining, but I just want to begin with by welcoming everyone to really this webinar on techniques for minimizing blood loss. It's presented by Setting Scoliosis Straight as well as the Harm Study Group. Just briefly, we're going to be focusing on really, understanding and managing blood loss. We have some great speakers who will be focusing on understanding how we measure, what are the critical factors for blood loss, and then looking at different techniques, both pre-op, intra-op, and post-op, to really help minimize blood loss. And then we have a few surgeon experts who will follow on some of their own personal techniques and how they've minimized blood loss as well. So we are sponsored by VB Spine, who we'll hear a few updates from. But if we can get to the next slide, Harvey. So myself, I'm Bert Yazzie. I'm one of the orthopedic surgeons up here at Seattle Children's Hospital, who will be co-moderating with Nick Fletcher, who's a stellar spine surgeon who will learn a lot from about blood loss as well. He's an orthopedic surgeon at Children's Healthcare of Atlanta. And our honored guest speakers are actually Jon Schoenecker, who doesn't do any spine, but is actually going to do quite a bit of education for us on understanding how we can minimize our understanding blood loss. And then we have really a great group of Harm Study Group members who, Terry Ishmael, Suken Shah, Jennifer Bauer, and Josh Pahys, who will go through a little bit on their various talks on how to help improve our surgical outcomes by minimizing blood loss. Next slide. And again, we have some additional guest speaker, Ed Macy, who is the Senior Director for Sales for VB Spine, as well as Alvin Jones and Dan Hedequist, who are part of the Surgeon Performance program through Setting Scoliosis Straight. We do ask you all to submit your questions through the Zoom Q&A. We're going to have various members of our faculty who will be answering those questions, and then some of those questions we'll also bring to the rest of the group to make sure that we have a really great education experience here. Next slide. These will be our topics. I'm not going to go ahead and read or go through them. Next slide. And I just want to talk a little bit about Setting Scoliosis Straight. So we're a nonprofit organization. We've been going strong for, if I do the math right, about 8 years there. But really, we're the nonprofit behind the Harm Study Group, which has really been, we just celebrated our 30 years. And we really are here to better understand the discoveries and advanced techniques in the treatment of scoliosis in children's and adolescents worldwide. And we really do have a vision of a future where children with scoliosis can really have the ability to live a happy, healthy, and productive life. Next slide. So I'm going to go ahead and first introduce Ed Macy again, Senior Director for Sales for VB Spine.
Thank you very much, Dr. Yazzie. Appreciate the time from everyone this evening. VB Spine is pleased to continue our support of the Setting Scoliosis Straight Foundation and Harm Study Group, about a 10+ year journey that we've been on. It is a transition for us, a transition from the spine business that was previously owned by Stryker. For those who are not aware, we have new owners. And while the ownership of our business is new, this is not a new space for them. The Scoliosis brothers acquired this business. I'll point to a couple things: 17 acquisitions in the neuromuscular space, 42 businesses that they've founded and scaled. You'll notice one of them on the screen, MICRA, a clinical research organization. I'll touch base on that. So this is not a new thing for them. This is about creating a standalone spine company that we think can meet, hopefully, your needs in a couple of areas. The first one, technology development. We're eager to get our pipeline in a more nimble organization, perhaps moving quicker and faster to bring solutions for you and your patients. Clinical data and research, as I mentioned before, the brothers had ran one of the largest clinical research, reimbursement, and regulatory affairs organization. That passion continues on, and education and training will remain a focus for us. It has always been. while many things, like I said, are changing, new branding, new relationships, et cetera, the one thing that will not change, the passion, the commitment, our desire to partner with groups like yourselves, and certainly our 600 plus person support organization that spends times with you in the operating room, servicing you, supporting your staff and the patients that you treat. So we're appreciative of the opportunity to be with you on this journey, and look forward to continuing down the road. Thanks very much for the time tonight.
Well, I really appreciate that, Ed, and really appreciate your partnership on both this webinar and helping improve the lives of kids with scoliosis around the world. So our first speaker is going to be Nick Fletcher, my co-moderator, who'll be talking about blood loss estimation.
Thank you. Thanks to all for turning out. This is a subject that's sort of near and dear to my heart, probably a lot of our hearts, because it's something we deal with daily. So this is looking at sort of how we estimate blood loss. And as I'll get into it in a second, I think a lot of times this is also could be subtitled, how many gumballs are in the gumball machine? Here are my disclosures, none of which are relevant tonight. So I took on an interest in this area a little while back, and it started with a little project that I had put together. And I started out looking at our HARMS members, and I picked a group of surgeons and I looked at blood loss in typical AIS cases. And I'm not going to tell you who surgeons 1 through 4 were, but they're on this page somewhere. And the interesting thing was, if you look at the average blood loss on again, a routine AIS case, the blood loss was all over the place, from 340 to almost 1,500 cc's for the same exact cases. So as much as I'd like to think that there's a wide variety of skill sets, I think that these are all talented surgeons and that likely we're just estimating blood loss differently. And this has been borne out in some other work that's been done. This is a paper or a presentation that Barry Lahner gave out of our group back in 2018. And this looked at the correlation coefficient between EBL and cell saver transfuse. And you can see a really wide variety here, again, suggesting that there's a large variation in the amount of blood loss that we estimate. And then again, in line with that, how much blood is then transfused. And so again, going back to my original analogy, I think these two things are actually relatively similar. This has been shown in some in vitro studies. This is a paper done out of Cleveland where they took porcine blood in low, medium, and high volumes and then posed to a group of providers, anesthesiologists, surgeons, nurses, and techs, what the blood loss was when they sort of scattered around the field, and they knew what the actual blood volume was. And you can see that as that volume gets higher, as is common in spine surgery, our error becomes greater. And we in surgery are actually the greatest culprits here. I think a lot of it comes down to how you're measuring your blood loss. And there are a lot of ways to do that. When we looked at that in our HARMS series, we found that in fact, there's a wide variation. So if you look at a lot of our papers, this is where the data is generated from. But in general, you can measure blood loss in 3 basic ways. First is gravimetric, second is volumetric, and then the third is a hematocrit-based or formulaic method. Gravimetric is probably the simplest. You take the bloody laps, you know how much each lap weighs, and you just take out the dry weight, but it doesn't account for irrigation. Volumetric is probably one of the more common ones. This is where you take the volume in the cell saver or the suction and you take out the irrigation. But again, you don't really know how much irrigation you're putting in. The cell saver perfusionist is saying, how much did you use? And you go, I have 100, but you don't really know because again, you're not good at estimating these things. And then there are a variety of formulaic-based or hematocrit-based methods. And these are considered the most accurate. They also require the most work, but they take into account things like the hemoglobin at the beginning and the end, and the known volume of the known blood volume of the patient, how much you've given from transfusion, and then the average hematocrit to the case. But you need these values, these hematocrits, these hemoglobins. You need to have an accurate fluid balance and need to know your transfusion data. But clearly, a formulaic approach would be the best. This gives you the most consistent outcome. And there have been a lot of ones that have been devised, the Burke formula, the Gross formula, the Camarasa formula, and then we used the Waters formula at CHOA for a while. And in fact, I sort of pitched this to HARMS until some of the other data that we did on top of it. The question has come up over time, how do we validate any of these? So all of the papers that you've ever read have been based on some level of estimation. And the question is, how do we validate those? Well, I decided with a partner of mine, an anesthesiologist, to take this on using a product known or developed by the Daxor Corporation called the BVA 100. And this uses what's known as an indicator dilution technique, where you basically can take a radio-labeled albumin at a very low dose. The radiation is less than a chest X-ray. You inject it at the beginning of the case, and then you take serial measurements throughout the surgery. And with this, you can know the exact blood volume at any one time. And it's been shown to be accurate to within about 2.5% of the true blood volume. This has been used in the cardiac literature and showed to be very accurate. It's also been used in the ICU for very complex patients who need very tight blood volume management. We had 30 patients and a relatively cohesive group of providers, 2 surgeons, 2 anesthesiologists, and 1 anesthetist. We maintained euvolemia through IV fluid replacement and didn't give back any cell saver or blood transfusions until after the surgery. And then we took all those formulas that we were able to find, including a couple of others. We had the surgeon, the anesthetist, and the circulator all estimate what blood loss would be. And what we found is that most of them were pretty poor. The Waters formula, which we were using, was probably the best of the ones that were out there. And you can see how poor like surgeon guess and circulator guess were. But Tom Errico, a proud member of the harm study group, had said, hey, Nick, why don't you try cell saver ×3? We use it. And we thought, well, it's simple. We can add that in. And lo and behold, Tom was right. If you look at this, the interclass correlation coefficient was the highest of the group. And then once we did a little bit of a adjustment for the hematocrit, we were able to bump that up a little bit higher. And with that little bump, we found that this had less overall and proportional bias with the hematocrit adjusted formula. And all of these were much better than the top performing of the other formulaic methods, which was the Waters formula. So in conclusion, blood loss estimation is really inherently flawed. There is a lack of standardized estimation that limits data analysis. And again, this is what our literature is built on. And it's tough to assess interventions like bone scalpels or bipolar sealers or the things we'll hear about today when we're all using different ways of estimating it. We found that cell saver multiplied by 3 was the most accurate and simplest. And you can get even a little bit better if you adjust for the hematocrit. So that's what we use at our center. And I think the key at the end of the day is to develop some level of institutional consistency. And I would try to stray away from guessing as much as possible. Thank you, and I look forward to the rest of the presenters' talks.
That's great, Nick. And please, we're looking at the Q&A, so please direct any questions there for Nick, and then we'll, after our next talk, we'll get to those questions. So our next speaker, we actually feel very honored to have Jon Schoenecker, who actually will be making his way up to see us next week, but we're actually really pleased that he was able to kind of tell us a little bit more about the science behind bleeding. And again, he's an orthopedic surgeon at Vanderbilt in Nashville, Tennessee.
Great. Thank you guys very much for letting me join you. Whenever Dr. Fletcher calls me with a challenge, it's hard. And this one is I have 10 minutes to teach coagulation and how it actually, you can think of it practically when you're doing spine surgery. So I've got a lot of animations in here, and feel free to send me questions through my email as well. There we go. So what big thing is that in this talk, I'm just going to be talking about bleeding. There's a lot of other aspects about coagulation that you need to know about that we can do in another time, but this is all just about bleeding. So the purpose of this talk is to go through coagulation, explaining what primary hemostasis is, secondary hemostasis, the most common reasons for bleeding in surgery, and then why all hell breaks loose, and why TXA works. So starting off, we're going to talk about primary hemostasis. So platelets are the main thing that contribute to primary hemostasis. And the best way to think about them is they are so ready to bind to any injured tissue. So when you have an injury, there are multiple receptors on those platelets that will bind to the exposed collagen, to von Willebrand factor on endothelial cells, or to fibrinogen. These are the main things that it sticks to. Then, in addition, in that microenvironment where you had your injury, there are multiple things that will activate the platelet. Thromboxane, ADP, and thrombin are the main 3. When they activate the platelet, the receptors for binding to all of those things for a platelet plug are much more accessible. And so it's very easy then for that activated platelet to bind to collagen, the endothelial cell, and then through fibrinogen, cross-link, which ultimately is what makes that initial platelet plug. So this happens within about 5 to 10 seconds. You then activate secondary hemostasis. Secondary hemostasis is what everybody had learned as the waterfall cascade, which was pointless in terms of memorization. Clinically, the way to think about it is secondary hemostasis is the interaction of injured tissue with that platelet. So to know secondary hemostasis, all you need to do is understand how coagulation complexes are, what their anatomy essentially is. With that anatomy, what you have is that you have an anchoring protein, which is usually tissue factor in injured tissue. It binds a protease, and it requires calcium and phospholipid to assemble. That complex then activates a protease that goes on to the next complex. So extrinsic 10ase activates the zymogen factor 10 to activated factor 10. That then goes to the platelet where you have what's called the prothrombinase complex, and that's where factor 5A is the anchoring factor which binds that 10A, and that's what activates prothrombin to thrombin. So it's very useful to think of how important it is to have your injured tissue interact with that activated platelet to generate thrombin to make the clot that you need. That thrombin is then what cleaves fibrinogen into fibrin, starting off your clot. There's a key aspect that the platelet brings along with it, which is really important for understanding bleeding, is the intrinsic 10ase complex is on the platelet. And that's where you have factor 8, which binds factor 9, and it also converts that factor 10 into factor 10A, feeding the prothrombinase complex. So in terms of a model of understanding coagulation, realize that that extrinsic 10ase with tissue factor is the spark that gets everything going, but you really need that intrinsic 10ase to be the gas to lead to tons of thrombin being made and effectively making a very rapid fibrin clot. So with that model, it's actually much easier to understand the more common reasons as to why kids will bleed in scoliosis and other surgeries. Hemophilia is simple now in understanding this. This is a platelet disease. And what happens is that with hemophilia A, you either have a mutation or deficiency of factor 8, making it so that the platelet can't accelerate coagulation, or hemophilia B, in which you have less factor 9 or a mutation. And both of these can be treated effectively if you know what you're missing with very good either factor replacement or other platelet modifying drugs. The more common one that we actually come across that often is not diagnosed is von Willebrand disease. And the way to understand von Willebrand disease is that von Willebrand factor is essential for endothelial cells when they're stimulated to reach out and grab onto that platelet. You can either have a loss of von Willebrand completely, or you can have mutations of it. Either way, you can use pharmacologics like vasopressin to stimulate endothelial cells to actually produce more of that von Willebrand factor. And this is a very important one to know about. This is, again, one of the most common ones that we come across. Another one, especially in the neuromuscular population that is under-discussed, is the vitamin K deficiencies. And that is both a nutritional loss, but also a lot of the anti-epileptics will block the actual modification of the coagulation proteases that are needed to bind to the surface. So with the deficiency of vitamin K, either preoperatively or postoperatively, it makes it so these complexes cannot form correctly. They've actually had good studies now in the total joint literature that shows that vitamin K replacement can actually happen in about a half an hour to an hour through intravenous routes. And actually, pre-operative vitamin K before total joint arthroplasty reduces blood loss in surgery. So it's definitely something to be thinking about. I think we probably really underdiagnosed this. And then the big one we found out here at Vanderbilt, we have a nice paper on this if you want to look at it, was the dilutional coagulopathies from too much fluid during surgery. It effectively does the same thing as is the vitamin K deficiency. And obviously, you can work with your anesthesiologist to come up with protocols to prevent that. Then the final part before when all hell breaks loose is a fibrinogen deficiency. What we were able to figure out with our coagulopathies in spine is that unlike adults, fibrinogen actually becomes rate limiting before platelets. And that's because kids start with about half the fibrinogen levels. This has been really exciting because this leads to the idea you can have fibrinogen cryoprecipitated and lyophilized in the OR. And it's a great potential going forward of using fibrinogen giving back during surgery instead of giving FFP, as often the fibrinogen is the rate limiting part. And so again, we have lots of treatment for that. So the final part of this is what happens when all hell breaks loose. And realize that what I mean by that is most of us are already dealing with this right now, and that is when fibrinolysis gets activated when it should not, that's when we start seeing oozing when we didn't have it before. So the way to understand this is the fibrinolytic system simply is plasminogen, which when it gets activated by either TPA or UPA, becomes plasmin and is essential for tissue repair and resolution of clots to get rid of fibrin. What happens in our surgeries, though, is the main binding site for plasminogen is actually fibrin and fibrinogen. So we load our clot with plasminogen immediately during these cases. But what happens is that there's a TPA bolus that actually comes out, especially in neuromusculars, that will go and activate that plasmin during the case. This initially first destabilizes the clot itself, but then also the platelet plug, and it can lead to emboli as well as rebound bleeding. So along those lines, what then ends up happening is that we want to fight back. So this is where we start upscaling coagulation and can lead to having problems with patients having things like multi-organ dysfunction syndrome afterwards, because the platelets come back, and to not have this be insanity is that they lay down their fibrin clot, but then they also attract neutrophils to the site. The neutrophils help go overboard as they supply tons of extrinsic tissue factor as well as other procoagulants, leading to a much thicker clot. But then they also release DNA nets into the clot, which makes it so that when that plasmin comes around, that clot's fortified in a way that makes it so that it cannot break up that clot. And so the hypercoagulability or hyperinflammatory state we can see after surgery, actually one of the main things that causes it is the initial loss of that clot. So how TXA works quite simply is that it is a soluble lysine that goes and it blocks the ability of plasminogen to bind to that clot temporarily, making it so the plasmin can't localize to the clot and release it. So I hope that this gave a good background for starting to think through molecularly the problems we have with bleeding, and think of that primary hemostasis, secondary hemostasis, these common reasons for bleeding, and why that fibrinolytic activation is so important to block before it starts, and how that TXA works. So thanks again for the invitation, and look forward to discussion.
Great. That's really appreciate it. And I will say personally, thank you for the pictures. It was very helpful to get your point across, at least for me. So John, I do want to ask this question of you because I actually don't know how many surgeons are familiar with some of this. And so there's a question regarding do you use fibrinogen concentrate? They've moved to, I think this is from Sandeep Tumber. They've moved to Fibriga. I'm not sure what that is. It's virally inactive, faster than cryo, and it also has factor 8. So I'm not sure what all of that is. So I was going to happy to
Yeah,
hear.
we are moving towards doing it. We have not done it yet. I've been talking with our anesthesiologist about it. This has become a really big thing. There's right now about 8 or 9 companies that are really pushing this hard because the FFP component to this, it's pretty dirty. There are so many things in FFP that can really elicit a pretty big immune response. And the concept is breaking this down to just giving back what you need, like these fibrinogen concentrates. And factor 8 along with it, it can actually be very good, and realize that that factor 8, what it actually carries with it that probably is more important is more von Willebrand factor. Is factor 8 you can't give by itself, it's complex with von Willebrand factor. So giving those together really helps the platelets stick to where they need to stick.
Great. All right. Well, I know that the other question was otherwise answered in the chat, so I think we can go ahead and move to the next speaker.
Great. So I'm going to introduce Terry Ishmael from the Shrine up in Philadelphia, who's going to be talking about our preoperative techniques for minimizing blood loss.
Thanks, Nick. Hey, everybody. Yeah, so quick talk on preoperative techniques. Sorry, we're not advancing. So yeah, we're going to go through a little bit of the background, a little about history and physical examination, and I think Dr. Schoenecker just kind of hit it out of the park with antifibrinolytics, and then we'll talk about what to do when there are. I'm sorry, who's advancing? So excessive intraoperative blood loss is a challenge that we all face daily in the operating room. Specific patient populations present unique problems. Neuromuscular patients have long, difficult procedures, high blood loss, and high complication rates. Jehovah's Witnesses refuse transfusion of blood and blood products. And then we also have patients with bleeding disorders. I'm going to touch a little bit more on patients with neuromuscular scoliosis by talking about Emmett Jane's paper in JPO in 2017. It looked at 272 patients, and 108 of these patients lost at least one blood volume. So if we stop to think about this, I mean, if this is one set of patients that we deal with commonly, then maybe we should take a look into things a little bit more deeply. And something that's been pressed in upon us from the early stages of medical school are, getting a good history and examination. We want to make sure that we look at the patient's general health. Are they well nourished? Do they have any history of bleeding gums with brushing their teeth? Do our female patients have heavy menses? What about their surgical history? Have they been transfused before? Are there any religious or cultural barriers to receiving blood products? What about their family history? Any history of bleeding disorders? Are they on any medications such as aspirin or NSAIDs? And again, in our neuromuscular patients, are they on anticonvulsants such as valproic acid? And then our physical examination, again, is just to make sure that they're generally healthy, no open wounds or any bruising. Now, do you need to get labs? There have been a few studies that have been out in the literature over the last several years that have shown a significantly increased cost with obtaining labs, looking at a coagulation profile. Some studies have recommended that just getting a CBC and type and screen is significant for AIS. But our patients with neuromuscular and syndromic scoliosis, as well as our revision surgeries, it's probably a good idea to get coagulation labs just to make sure that you're not going to come across anything that you haven't expected. In addition to also maybe some nutrition labs in our neuromuscular patients. I'm not going to belabor this too much, but Dr. Schoenecker kind of went through all this, and it's been antifibrinolytics have been shown to be efficacious in decreasing blood loss. There are multiple different dosing regimens out there. The most important thing is to find one that it works for you, and and just make sure that it's administered appropriately by your anesthesiologist. But what do we do when transfusion is not an option? There are a few options out there. Multiple authors have demonstrated the efficacy of using dual surgeons, both in AIS and neuromuscular scoliosis. So it has been shown to decrease operative time, decrease blood loss, rate of transfusion, and also complications. We do this routinely for our larger neuromuscular curves, but it can also serve you in patients with Jehovah's Witnesses who do not want to receive blood products. And then other options are autologous blood donation. This was initially popular during the 1990s due to perceived risks of transfusion transmissible diseases. but the increasing safety of allogenic transfusion has led to decreased usage, but it may have a specific role with specific diagnoses. Thank you.
That's great. Thanks, Terry. Next up will be Suken Shah, who's going to be talk about what to do intraoperatively.
Great, thanks, Nick. Everything good with my screen? Full display?
Looks great.
Good, thank you. So fortunately, since the 90s, transfusions have steadily decreased based on our further knowledge of how to intervene with the coagulation cascade, as you heard, and then numerous interventions. And even the more recent data from the HARM study group with best practice guidelines and some consensus statements, you can see that not only has the trend for blood loss shown improvement, but the variability between centers and surgeons has also improved, which means we're getting better. And over this period, there's been up to a 3-fold reduction in blood loss at some centers with iterative improvements, some of which we can discuss later today. Well, why is all this important? Bleeding is almost directly related to the risk of allogenic transfusion, which have their own set of perioperative morbidities, complications, cost, and in some instances, a direct relationship to infection, even in spine surgery, as demonstrated by the Barrett Woods article. But if you just lose blood and don't need a transfusion, there's morbidity from that as well. And you can see some of those issues related here. And some of the first things we do when we lose signals related to a neurologic impending disaster is we ask about the blood pressure, the temperature. We replace some blood if we're losing blood. And so it's a very important parameter while we're doing spine surgery. And it seems that when you're planning for blood loss, some of the most important variables is how long is the surgery, how long is the fusion you're actually doing. This older data from Tim Kuklo, 200 cc's per level, is probably down to about 25 cc's per level at most centers. We have lots of tools to significantly reduce perioperative blood loss, and we can group those in terms of preoperative, which Terry just talked about, intraoperative, and postoperative. And you can do any number of things that are based on superstition, or you can look to the evidence. Autologous blood donation was very popular 20 years ago. We would put our patients through 1 or 2 preoperative donations a month prior to surgery. It had very little impact on their intraoperative hematocrit, but it was significantly expensive. And in later literature, we found that we were wasting a lot of these units as we got better at promoting effective blood loss mitigation. And as the cost came to light, as well as the severe anxiety associated with having a 12-year-old or 13-year-old donated unit of blood became problematic. And so we've pretty much abandoned that option unless you have a specific comorbidity or interest in doing that. Erythropoietin, in terms of a preoperative pharmacological intervention, very important in the oncology population, but not so important with our patients. It's not cost effective. It's a very expensive medication and it has some side effects even in healthy people, but our current intraoperative strategies have really put EPO to the wayside. You heard a lot about TXA, and I would say that's really the main actor here. It's been widely studied. You heard how it inhibits fibrinolysis by inhibiting that plasminogen activation. It's very effective, very safe, and quite cheap, and has replaced really most other pharmacological interventions in our operating room. It's been very well supported in spine surgery. This is our work showing in the highest risk patients, it does obviate the need for transfusion in many patients, but definitely points towards decreased blood loss with no adverse effects. It's also been shown to be very effective in patients receiving a vertebral column resection. And in those high-risk patients, it then went to widespread use in AIS because of its safety profile. So you can see about a half reduction in blood loss for even AIS patients who are relatively healthy, as well as a reduction in transfusion is what we're really after. And this was shown in a wide data of NSQIP patients. They actually shown a significant difference in allogenic transfusion with TXA. And finally, in the Cochrane review, you can see that with TXA, in a systematic review showed a reduction in blood loss, a decrease in children receiving blood transfusion, no adverse effects. The safety of it, I wouldn't say remains unclear. I would say it's pretty well tolerated. The optimal dose remained unclear until our colleagues at Boston Children's told us that the 30 loading dose with the 10 maintenance dose seems to be the sweet spot in terms of the dosage. And this can be continued through surgery. It does not need to be administered post-operatively, although in some high-risk patients that might be necessary. And then autologous cell saver. This also has been shown to significantly reduce allogeneic transfusion, in which most cell saver groups received about a unit less or frequently no allogeneic transfusion in AIS cases when used for that type of surgery. And it seems to be cost effective, although when you look at the cost of $650 rolling the machine in, plus the disposables, in some of our single curve types, I've gone to not using cell saver routinely, but rather more in the high-risk patients, the double curves, or those who require significant 3-column restoration. Positioning, not much downside here, but not much evidence either. If you hang the belly, it seems to not impede venous return and decrease epidural bleeding. So I would say it's a pretty good practice with negligible risk. Other intraoperative techniques include this bipolar sealer device. This is an adjunct to our typical monopolar electrocautery, the Bovie. In one study, there was a decrease in EBL, no significant difference in OR time. We don't routinely use it, but I would say that the routine use of monopolar Bovie settings of 50 or more are probably just as effective. The ultrasonic bone scalpel is very popular for bone cutting, and when used to complete pontiosciotomies, seems to improve time as well as bleeding, and this is our standard as well. What about our anesthesia or our colleagues across the curtain? If they keep the blood pressure at a reasonable level, typically just during exposure, we can improve our time to exposure and decrease the amount of bleeding. And with nice monitoring, this is quite safe. But this is also the time where many of us are frequently giving a short-acting paralytic as well as hypotensive anesthesia. So I would say that use caution in high-risk patients and when in intraoperative traction, as this is a relative blind spot for us during that time. What about more hands? I would say this is also controversial. There's studies showing that 2 surgeons perform well. There's studies showing in AIS, it makes no difference. I think this has a significant educational impact on our trainees, and we try not to do it except in very high-risk cases. However, you can probably find articles to show that 2 surgeons decrease OR time, blood loss, need for transfusion, and some other post-operative parameters which are unclear how 2 surgeons would help that. But I think it's just been an evolution in care in multiple levels, making care better and safer for our patients. Other considerations, MIS, probably not a great thing in complex deformity surgery, although we all know our tether patients barely bleed. Anterior surgery is very safe in terms of bleeding and risk for transfusion. And the new kid on the street is topical use of TXA. Feroz Mianji recently had an excellent randomized controlled trial, which is in progress. The arthroplasty surgeons have shown good effects. Some people also use kaolin topic application and fibrin glue. So I would say this is the next frontier. Prior to closure, we may consider using some topical agents and then close the wound. Because I want to bring your attention to the hidden blood loss concept. Hidden blood loss is total blood loss minus estimated blood loss. And this is all that blood that we don't see because it's extravasated into tissue, ends up in a drain, accumulates in the field. And this can be up to 50% of your total blood loss. And this is directly related to the need for transfusion on post-op day 1. So I think it deserves some attention. Satoshi Takada at our center has looked at a predictive model, and about 30% lost greater than 15% blood volume. And this is important because this is when some of the shock mechanics are introduced and can cause systemic inflammation. Some of the risk factors in this predictive model were high BMI, low preoperative hematocrit, high curve magnitude, and fusing someone greater than 11 levels. And as I mentioned, the significant correlate to transfusion needed on post-op day 1. So more to come on this concept, but I think it's very important. So if I could summarize some of our best practice recommendations, use perioperative TXA unless there's a direct contraindication. Optimal patient positioning is easy to do prior to starting. Controlled hypotension during exposure of about 60. Meticulous hemostasis with whatever device you'd like to use. Intraoperative cell saver, maybe not for every patient, But where you expect to return something that might prevent allogenic transfusion, consider using 2 surgeons with increased case complexity, no drains if possible, to prevent some of that hidden blood loss. It's all about a disciplinary approach to making care better, benchmarking yourself, communicating with anesthesia, and auditing your practice to see if you can get better. Thanks very much.
Thanks, Suken. All right, we're going to round out this section with Jen Bauer from Seattle Children's talking about post-operative management, especially with regards to transfusion and drains.
Thank you. I have no related conflicts. So when it comes to post-operative blood loss, I really think that the stage is set at least 90% already by your intraoperative and preoperative practices. But for our post-operative care, we're really thinking about the goals of avoiding complications and having a faster recovery. And blood management is going to have a big impact on these things, whether it's related to their wound or just overall energy and stamina. So we're going to talk about the few things that I think we can have impact on in the post-operative period, like these things here. When we look at drains, this 2007 Cochrane review for all orthopedic surgery types stated that there's no evidence to support routine drain use, and that doing so led to a higher rate of transfusion. Since that early review, there's been a number of pediatric spine-specific studies that have had similar findings. These 3 studies looked mainly at deep drains, and each showed a higher rate of transfusions in patients that had the drains, but no difference in wound or other complications, which we might be thinking we're avoiding by using the drains. There's some recent support by Ilka Helenius's group that found lower opioid requirements when they use a deep drain, but they too showed higher total blood loss. The only pediatric spine superficial drain study that I could really focus on showed here that there were less saturated post-operative dressings if you used a superficial drain, but I think this might be related to an older closure method, since 70% of those that had the drain still had bloody dressings. In my practice, any drainage at all I consider an infection until proven otherwise. So I personally probably take a little bit longer to make sure there's really no drainage at all. And because of that method, I really don't use a drain. If, however, your closure does have an approach where you favor using a drain, which one should you use? Well, if we're really talking about blood management, this head-to-head comparison shows that there's obviously going to be so much more drainage out of a deep drain, but this showed no difference in wound complications. So as we're talking about blood loss, if you're going to use a drain, probably a superficial drain is going to be the one that should be favored. And since there's no strong data to support their use, there's similarly no strong data to support when to pull the drain. This study argues that since drain output hasn't been shown to correlate to hemoglobin labs, it shouldn't be used as a factor to consider transfusion. So based on blood loss, we're really not sure when to pull the drain. If we think about when to pull the drain, though, based on avoiding a surgical site infection, you might want to consider prophylactic antibiotics until you remove it. These 2 studies argue that because the drain tip becomes culture positive and many by about 24 hours, that would be a good time to pull it. However, these 2 studies contradict that finding and shows that surgical site infections really aren't correlated to the drain tip culture. So based on surgical site infections, I'm not quite sure when to pull the drain either. So if drain output shouldn't be a trigger to transfuse, what should be? Well, the best practice guidelines developed by several on this call recommends using a hemoglobin of 7 as the cutoff. Our protocol here at Seattle Children's is to get a CBC on post-op day 1, and if it's less than 23, we recheck it again. Otherwise, you might consider shifting this a bit for some less robust patients. Although we learned a lot today about how to manage blood management, I was very surprised that transfusions still occur at a pretty high rate nationally, so we do have some work to be done. If the transfusion isn't indicated, what can we do for our patients on the final leg of their recovery, which is happening at home? Since blood loss anemia in my patients really makes them pretty drained and therefore leads to a slower recovery, other things that I do for them is really just what I think we all do. Encourage movement, adequate hydration, and if really low hematocrit when they leave, I'll occasionally recommend some iron supplements for 3 months afterwards. So these are some post-operative strategies, but again, the best intraoperative and preoperative management strategies are certainly, I think, the most important. Thank you.
Thanks, Jen. Thanks to all speakers. Just because it was asked in the Q&A, I'm going to repeat it. But Sandeep also had a question about dosing of neuromuscular versus AIS for TXA. And Dr. Shah stated that the dosing is the same, 30 and 10, so 30 for the bolus, 10 for the maintenance, and you can go as high as 50 and 10 as a higher dose, which has also been shown to be safe in spine and in cardiac surgery. Jen, I had a question for you because I think you rightly stated that some of the concerns about older blood loss and dressings is probably related to closure, which I think is important for sort of our post-operative blood loss. Can you talk about your closure and how that, maybe a little bit more, and how you think that really impacts blood loss and post-operative management?
Sure. I think I do three things. One, I actually try to really close down the dead space. So I'll close a muscular layer first. Then I want to have 2 layers that are fully waterproof. So I expect the fascia to be closed, completely waterproof, which I do with a combination of interrupteds and running. And then I want my sub-Q to be completely waterproof. And I think that's where I take a really long time doing a lot of 2-ovicral interrupted sutures the whole way. And then I just close with a skin runner. That's really for cosmesis, I think.
That's terrific. Well, in the essence of time, I'm gonna pass this on now. I appreciate Terry, Suken, and Jen's talks. I'm gonna pass it on to Josh Pahys, who is going to introduce some real experiences from a couple of our surgeons who are participating in the Surgeon Performance Program.
There we go. So I just want to thank everybody for allowing me to be here. So Harm Study Group's been doing dashboard reporting for the last greater than 8 years now. We've had a significant number of patients, but Suken alluded to this earlier. When you're just sort of looking at things, turning the lights on, if you will, the Hawthorne effect, and comparing yourself to others, but also showing how everyone's doing. We've shown a dramatic reduction in OR time, about 20%, almost an hour, a third reduction in hospitalizations, and a 50% reduction in estimated blood loss, or maybe even more since we're actually now know how to calculate it. But these are just some of the improvements that we've all been able to make after looking at our performance versus others. So again, it can inform surgeon performance. It can provide comparative practice data, highlights where you are above or below the mean, and also in forums like this to identify ways to improve your treatment and decrease your variability. Another little carrot for this program, this is a fantastic component where it can be an alternative for self-assessment exams or SAE credits that are required for ABOS. You can get 10 of these per year for just enrolling. I believe it's down to 6 patients now per year into the SPP program, and you can get 10 SAE credits towards your board certification maintenance. That's what your little certificate looks like. Congrats to Salil for making it through. Anyway, it's super easy to get involved in the Surgeon Performance Program. It's just for quality improvement, not for research purposes. There's no protected health information that's transmitted at any time. You can get centralized IRB exemption through WERB, so it can be used in place of your local IRB if they take a long time, just like ours. Then you get a registry participation agreement, and soon after that, you can initiate your registry access immediately after getting that, so you can go right away. This shows a dramatic increase in the number of surgeons that are involved in the SPP program, starting at 8 years ago, and now up to over 200. Again, look at the number of cases that we've had. The Harm Study Group's been around for 30 years. We have 7,500 AIS patients, and the SPP program in a significantly shorter time has 8,000 idiopathic patients, but also CP patients, among others. So again, a lot of good data that's in there that can be available to surgeons for yourself, but also others. So if you want to get involved, I encourage you to contact us at the Setting Scoliosis Straight Foundation in the SPP program. Sydney Barnes is running this now and just doing an exceptional job. So check it out or take a snapshot of this QR code. And then with that, I will stop sharing and mute myself now officially and introduce, I believe, Alvin Jones is going to give us his first talk. So Alvin and Dan are both members of, Alvin's a member of the Surgeon Performance Program. Dan is as well, but also a Harm Study Group member. They're going to give you some of their little tips and tricks that they've learned as they are top performers in the, I think the top 10 or so within the group. So thank you guys. Alvin, take it away.
Good. Hope everybody can see my screen. Good. Okay. So I'm going to talk about my experience doing the Surgeon's Performance Program. No financial disclosures. This here is my Surgeon Performance dashboard. And, this is where you'll see where you measure up. And so I am in the first quartile, and that's the little green bar that you can see down there. And out of the 98, it looks like I'm number 9 with an average estimated blood loss of 243 milliliters. So I'm thinking that, for the most part, my intraoperative methods are very aligned with what Dr. Shah talked about. I do use a Jackson 4-post table. And so I do like to keep the belly free. That's one thing that I do think is a little bit different than some of my partners that I operate with. So I don't necessarily know what everybody else is doing on the other end of this. So I'm just going to tell you kind of what I do and some of the things I think may be different. So keeping the abdomen free is one of the big things I do that's different. I still do the TXA like most people. I use that bipolar saline radiofrequency sealer. I also use the bone scalpel like Dr. Shah presented. So a lot of the things that are in that intraoperative techniques I do. But one of the big things that I've noticed, and I feel like is one of the biggest reasons for my decreased blood loss, is really the anesthesiologist and how they manage the MAPs. And so probably over a year ago, I started noticing that, during the exposure, if it was really bleeding profusely, I'd look over the drapes and I'd find out like my MAPs were really high. And so sometimes I don't have my normal spine team, and I want to make sure then that whoever's in there knows that during the exposure, the MAPs do not need to be high, because some people feel like it's a spine case in our institution. We just got to keep the MAPs above 70. So in my cases now, and I've been doing this now for about a year, at the beginning, almost during the timeout, I will make sure that I communicate to whoever's on the other side of the drapes that during the exposure, I don't need the MAPs above 70. I'd prefer them to be below 70. And then I'll announce when I'm about to do my rod placement and correction. And that's usually when people will stop, that if it's a nicardipine drip, they'll stop that. Or if they need to, they'll use some vasopressors like epinephrine. So I think to me, that's one of the biggest differences that I'll do in my OR than when I see I'm operating in one of my partners' ORs. And it's had, for me, dramatic decreases in the amount of blood loss that I see during exposure. And sometimes, just like I think Dr. Shah was saying, I don't even have cell saver to give back. So it's actually been pretty remarkable for my AIS cases. And that's my technique.
Thank you, Alvin. Now we're going to turn over to Dan Hedequist over at Boston Children's. Dan?
All right. In the interest of time, I'll be quick, Josh. Can you hear me?
Yep, all good.
All right. Pretty much the obvious, really what Suken touched upon, TXA, bone scalpel. I'm a little bit different, I think, than a lot of people, as I don't tolerate hypotensive anesthesia at all. So I'll shoot my MAPs between 65 and 90 millimeters throughout the case. Above 90, I sort of know there's going to be a lot of bleeding, but I don't tolerate anything under 65, and I haven't found that to be a problem. Some simple things: flow seal and the nephrectomies, pontiostectomies. I think that's a big source of blood loss, and you have to ask yourself if you're going to do them, why you're going to do them, and how you're going to do them. Exposure, I irrigate a lot. I think since it's an SPP thing, I don't ever fall behind at the beginning. It sort of goes to John's point. You don't want to lose all your coagulation cascade products. So I start my TXA before incision, and I do it all the way till closure. I have a pressure discussion with the anesthesiologist, and really a shout out to Michelle and Josh and the team. I think you just want to commit to the idea that minimizing blood loss is a priority. It's not really about making a transfusion a never event, because I think you should really shoot for keeping your post-operative hematocrit as high as you can, because I think your patients recover a lot faster and improves your length of stay. It just makes them feel better. So SPP dashboarding has been pretty helpful for me. Follow your trends, and if you're not doing well, ask why and ask people about it. That's it.
Awesome. Thank you, Dan. Great job. Just a couple questions for you. Being in the harm study group for a while and then now at the SPP program, you sort of alluded to this, and Alvin did as well. Sort of his number one thing was managing blood pressure. What was your number one thing that you implement? I'm sure it's multifactorial when looking at your data from SPP. And then how long did it take you to really see a difference in your practice?
I think it's just been multifactorial in the discussions in here, and everybody talk, whether it's been TXA, bone scalpels, anything. I just personally for SPP, it's been more about for me length of stay, things like that's been more important to me than blood loss. So just sort of dashboarding against the group on a lot of different things I think is helpful. And if you're an outlier, you're not the first quartile, you're second quartile, third quartile, figure out what you can do to make better and set a goal and make yourself better.
Thank you, Dan. Suken.
Thanks, Dan, Alvin. That was great. You know, one thing that we haven't talked about directly is speed or efficiency. I don't want to say that the fastest is the best, but clearly taking too long leads to increased blood loss. So what kinds of things did you do, Dan or Alvin, to increase efficiency? Because that's been directly related on the N factor, right?
You know, my practice, I typically will have either fellow or resident, but you know, what I try to teach also, actually, one of the biggest things I have not mentioned, part of the blood loss is I will dissect from the spinous process, like subparalar osteally off the bone, and that really minimizes blood loss. The only places I don't do that is maybe up at the top, where I don't want to take down the interspinous ligaments, and I also don't take it down at the bottom, but actually dissecting directly off of the bone is one of the techniques that I didn't mention that really helps minimize the blood loss. But part also of doing that is I dissect out really wide at the beginning, and that's the part where maybe I'll spend 45 minutes to an hour. But after that, it gives me great exposure, and I do my pedicle screws, and that usually doesn't take very long. After I've got the anatomy, and I still do freehand technique, but once I can see the anatomy clearly, then it helps with the pedicle screw placement. And those usually take somewhere around 30 minutes, and then it's another 30 minutes to an hour of manipulating, trying to get the spine to where I like, then another 45 minutes close. And so I'm somewhere usually between 3.5 to 4 hours. And so that's my typical spine case.
How about you, Dan? And to that question, Alvin mentioned the freehand thing. Can you tell us about how robotics has impacted your blood loss?
Yeah, we wrote a paper with Michelle that's coming out. Originally, when I started, it bumped up my blood loss a little bit, and then had to do with drilling pilot holes, and I subsequently sort of stopped that, but I was able to sort of look at surgical time and blood loss, adopting a new technology and saying, okay, I don't think it slows me down, when in fact it did slow me down. I didn't think it made me bleed less, but it did make me bleed more. So I think that was one of the things about dashboarding and robotics, is just being aware. I think we all think we know the answer to ourselves, but when you dashboard yourselves, and you might figure out the answer is not, you might be better than you are, or you might be worse than you are. So.
Nice. Well, thanks for being transparent.
Well, I think with that, we're going to close this webinar. I'd like to thank all the speakers. I thought it was really a great, concise overview of bleeding from sort of start to finish during the case. And for those on the who are interested more, we have a YouTube channel. You can see the QR code right there. I was on this actually last week a couple of times. I think it's great. It's really good for patients as well. And so, go there and check it out, see what's available. And there's, more content added on a regular basis. And then again, just one more thing, check out our Setting Scoliosis Straight webpage. You can see where donations can be given, and we obviously appreciate that. This is a nonprofit organization that I think really contributes to spine care across the world. And then finally, we try to do this pretty regularly. You can see that we've got a number of webinars coming up. We've got a surgeon education webinar in November on revision techniques, which is going to be spectacular. And then one of the things that I've been very happy with for my own patients has been these patient education webinars. So we've got 3 of them coming up, 2 over the summer and then 1 in the fall, that I think have been very helpful for patients and their families as they're sort of going through the decision process here. So thank you all, and reach out with questions, and we appreciate the support of VB Spine.